In the name of God. Welcome back. In this video, we are going to have an ECG quiz. This is our today's strip, which belongs to a 75-year-old heavy smoker, presented to emergency department with retrosternal chest pain and diaphoresis since 3 hours ago. An EKG was obtained. What do you think about this strip? What is your plan? Like before, to make a proper interpretation, we are supposed to apply the 10-step approach. Let's start with the first step, that is standard values. Here, the calibration marker is 2 large boxes tall, and 1 large box wide and therefore, is standard. So, this is a standard electrocardiogram. Second step is cardiac rhythm. There are 3 main steps to interpret every heart rhythm. 1. Locate and examine P-wave morphology. Here, the P-waves are not obvious enough, due to the underlying tachycardia and broad-based complexes. But note that, in such an electrocardiogram, gaps between R waves often help us discover hidden P waves. Here are the gaps. As it is clear, there are obvious P waves in the gaps, which are negative in D1, D2, D3, AVF, and positive in AVR. Therefore, the P waves are non-sinus. Remember that. Non-sinus P waves are observed in atrial rhythms, including low atrial rhythm, atrial tachycardia, atrial flutter, and coarse AF. 2. Locate and examine QRS complex morphology. In this strip, the QRS complexes are uniform and more than 3 small squares in duration. So, the complexes are wide. 3. Describe the relationship between the QRS complexes and P waves, using PQRS ratio and intervals, including RR interval, PP interval and PR interval. Here, the ratio of P to QRS is variable, which leads to subsequent irregularity in heart rhythm. The PP interval is about 6 small squares. So, atrial rate is 250 beats per minute. On the other hand, the RR intervals are variable, so the rhythm is irregular. If we take a good look at the strip, we recognize that the rhythm is regularly irregular, due to the presence of group beating. The RR intervals of grouped beats are constant, and about 12 to 13 small boxes. In conclusion, group beating definitely excludes atrial fibrillation, because AF is a kind of irregularly irregular rhythm. In summary, the underlying rhythm in this strip is regularly irregular due to atrial flutter. Third part is heart rate. Since the heart rhythm is irregular, we should count number of QRS complexes in 30 large boxes, and then multiply by 10. Here, there are 11 QRS complexes within 30 large boxes. So, the heart rate is nearly 110 beats per minute, and therefore is above normal ranges. Fourth step is axis analysis. Here, the QRS complexes are positive in D1, but negative in D2. So, left axis deviation is present. In this strip, left axis deviation is due to left anterior hemiblock. Fifth section is examining the P waves. As we already said, the P waves are non-sinus. Remember that, when the P waves aren't sinus, surface EKG is no longer reliable to identify atrial abnormalities. Sixth step is the PR interval. Remember that, in atrial arrhythmias, including atrial flutter, the PR interval can be variable and therefore, has no practical significance. Next part is QRS complexes. As usual, examine 4 items to establish the complex changes. 1. QRS duration. As we already said, the complexes are broad. Remember that, sometimes marking the beginning and ending of QRS complexes, like this tracing, is difficult. In that case, we must scrutinize all leads, to determine the exact start and end point of QRS complexes. Here, in V1 and V2, the start and end point are clear. So, the QRS width is about 4 small boxes and therefore is broad. The presence of QR pattern in V1, with concomitant slurred S in V6, establishes RBBB. 2. QRS amplitude. As it is clear, the QRS complexes are more than 5 mm in limb leads, and more than 10 mm in precordial leads. So, they are not low voltage. On the other hand, none of the criteria of ventricular hypertrophy is present. In general, the QRS complexes have normal voltage. 3. R wave progression and transition zone. As you see, there is a tall R in V1, but small r in V6. So, there is reverse R wave progression due to intraventricular conduction delay. 4. Look for pathologic Q waves. Q wave is considered pathological if the duration and amplitude exceed 1 mm and 1/3 of complexes respectively. According to the definition, there are pathologic Q waves in V1 to V4. Remember that any Q in AVR is considered as normal. In summary, the complexes are wide due to RBBB, and have pathologic Q waves, possibly due to myocardial ischemia. Next part is examining STT changes. To determine ST segment changes, first mark J points. Here, the J point is not obvious enough in all leads, except V1 and V2. As you see, there are ST segment elevations in V2 to V6, D1 and AVL. No particular ST depression is present. So, we have ST elevations in extensive anterolateral territory. The ninth part is QT interval. Remember that, when QRS complexes are wide, like our case, measure JT index instead of QT interval, to see if the ventricular repolarization is prolonged. JT index is calculated using this formula. As it is clear, JT index is approximately 6 small squares. So, the JT interval is about 240 millisecond and the JT index, according to the formula, is 98. Remember that JT values greater than 112 is considered as abnormal. In summary, the JT index is within normal limits. The final step is overall interpretation. Before going through this part, if you liked this video till now, please subscribe me and ring the bell for further videos. To interpret our EKG properly, we are supposed to make a list of abnormal findings. In this strip, the abnormal findings are: atrial flutter, left axis deviation due to left anterior fascicular block, wide complexes due to RBBB, pathologic Q waves in anterior leads, and ST elevations in extensive anterolateral territory. The presence of RBBB with left anterior hemiblock establishes bifascicular block. Pathologic Q with ST elevation and concomitant chest pain is highly suggestive for acute ST elevation myocardial infarction. So, this tracing is suggestive for atrial flutter, with acute extensive anterolateral ST elevation MI, and bifascicular block. Let's go through several important tips. Remember that acute ischemia has various types of electrical and mechanical complications. Bradyarrhythmia, tachyarrhythmia, and conduction abnormalities are well-known electrical complications of acute ischemia. Bradyarrhythmias include sinus bradycardia and heart blocks. Tachyarrhythmias are often atrial flutter and fibrillation, although PSVT may be seen as well. Conduction abnormalities include bundle branch block and hemiblocks. Therefore, in this tracing, atrial flutter, RBBB, and left anterior hemiblock may be thanks to ongoing acute ischemia. Right bundle branch gets most of its blood supply from the LAD. So, acute RBBB can develop from acute coronary occlusion. RBBB is a high-risk feature in acute ST elevation MI, especially if new and accompanied by left anterior hemiblock. New RBBB in acute anterior ST elevation MI is associated with larger infarcts, higher rates of heart failure, heart blocks, and higher mortality. These patients usually have poor prognosis. Thanks for watching this video. If you like this video, please subscribe me and ring the bell. Good luck.